welcome everyone. I'm Péter Misnyovszki and I'm here to present my 6 months progress on my PhD topic, which is about violent death cases, the environmental factors and the diagnostic methods. So my vision on this topic is that in the near future we are going to be able to provide cause of death much faster and with a lot more available techniques than it is available now. And my spot in this, which I strongly believe we can achieve, is finding the place of autopsy techniques and evaluating and exploring environmental risk factors. We are working on 2 topics as of right now. One of them emphasizes the importance of the autopsy techniques, and the other is emphasizing the environmental factors. So my first topic, which is about the autopsy techniques, is asking whether we can replace autopsy with these techniques. What are these techniques? These techniques include the PMCT, postmortem computed tomography, with or without angiography, and the other one is postmortem magnetic resonance imaging. Both of these topics are capable of finding lesions without opening the deceased's body. Thus, they can help with easing cultural and religious tensions which arise when an autopsy is performed. Unfortunately, however, these techniques are available in some countries. They don't have a really defined role in a forensic setting as of right now. So we pose the questions that can these postmortem imaging techniques, autopsy techniques, replace autopsy? And we had a population of all the deceased who underwent autopsy, and at least one of the intervention methods, so PMCT, postmortem computed tomography, or postmortem magnetic resonance imaging. And as a comparator to these interventions, obviously we used autopsy, which is considered as a golden standard. We will return to back in one of our slides later. And the outcomes are the diagnostic accuracy parameters. So, for our meta-analysis, we did a systematic search in 5 databases with the visible search key, and we found more than 5,000 or almost 5,000 relevant articles, of which 110 were available for data extraction after a careful full text selection. We found many outcomes, and we pooled them into 7 subgroups, of which I'm going to share with you just the tip of the iceberg, as you can see there, because of the time limitations of this presentation. As our first results, you can see the first 2 forest plots, which are on the sensitivity and specificity of PMCT on traumatic soft tissue injuries and bleedings. This is a pooled result. And as you can see, the sensitivity covers a rather large range from 0.20 to 0.97, while the specificity is covering a shorter range, and it has a little bit higher value. So let's just get to the elephant in the room. We have a very high heterogeneity. As you can see, it's 93 and 97%. So why is that? After careful evaluation, we found that it is most likely because of the difference of the experience between the observers and because of the difference of the reporting techniques that was used in the articles. And this is concordant with what one of the previous meta-analyses found. They also found that the I values are quite high, although they didn't give a proper explanation to that. So one of our next projects might be to provide a proper unified reporting system to report all the CT and autopsy comparisons. Then the same results are shown in a 2-dimensional diagram, and you can see that the summary estimate is on a very low false positive rate, which is good, but unfortunately the sensitivity is only mediocre at best. So at this point I was thinking that should we drop all that we worked so hard for? So this basically means that PMCT cannot replace autopsy as a whole. Obviously, this is not the case. So we can still keep the results, not all of them, and we cannot replace it wholly, but we can keep some of the results. So after we have a CT examination, we can have a positive or a negative result, and we can decide whether to keep the result based on positive and negative predictive values. The twist in all this is that these values are highly prevalence sensitive, thus you have to take prevalence into account. These are the calculated values with the given sensitivity and specificity, and you can see the prevalence on the left side. This means that while you have a high prevalence, you are most likely to be accept the positive results, while if you have a low prevalence, then you are most likely to be able to accept the negative results. Of course, this even poses other questions and more projects to define the prevalence of different injuries and lesions. So what we can do in these cases, we get the result from the PMCT. We check for the specificity and sensitivity of the included lesion. We account for prevalence. Then and after, only then can we decide to accept or discard the results. One other subgroup I would like to share with you is the PMCT results on skeletal injuries, in which you can see the sensitivity and the specificity are quite high. So these are very promising results. Of course, the heterogeneity is, because of the same reasons, is still quite high, but this is something we can work this, and this means that in the PMCT might be able to replace autopsy if we think only about skeletal injuries as a whole. The issue with this is that in this case, autopsy is behaving like an imperfect golden standard. This meaning that when we had several cases which we considered false positive, which were visible on the PMCT and which were not visible in the autopsy, and in reality, there are injuries in these cases. The sensitivity and false positive rate are present in the 2 dimension, and you can see the summary estimate is on the upper left corner, which is quite good for us. And to provide a clear picture, I gave the positive and negative predictive values too. As a summary, PMCT can be used in several cases to replace autopsy, and we need 2 things to do this. We need a unified reporting system and studies on prevalence. My second topic is forecasting by weather, where we try to find whether there is an association between environmental weather factors and the incidence of suicidal death cases. Unfortunately, even though the number of suicidal death cases is dropping in Hungary, it is still an important healthcare and social and financial issue, with having more than 1,500 cases each year in Hungary. There are available publications on this, but some of them are more or less contradictory. So we have the aim to find some kind of a solution for this. And the population we are evaluating are all the people in Budapest, Pest, and Nógrád counties. That is basically because our registry covers those areas, and the exposure is a sudden change in meteorological factors, which are, some of them are listed here, and the outcome is obviously the incidence of suicidal death cases. And our hypothesis is there is some kind of association between these 2. And should we find that there is an association, that can help with the proper distribution of the available resources which can be used on the prevention of these suicidal cases. We have a single center registry in our department which includes all the non-natural death cases, and we have variables present such as date of birth, cause of death, and toxicology data. We are planning on finishing both of these topics by this summer. And here is the quote I would like to share with you. It's quite long, so I will give you time to read it during the discussion, and I'm open for any questions. Thank you.
Thanks. If you could conclude for which cases or for which subgroups do you really suggest virtopsy instead of autopsy? You mentioned in several cases, in some cases, but in details, to whom do you think it's really good?
Okay, thank you for the question. So it's really reliant on the country's jurisdiction where you can use it. So in Hungary, it's difficult because in cases when there are a lot of injuries and skeletal injuries and bleedings, we have to carry out an autopsy, so it's out of question. But in other countries, like in Germany and Austria, they don't always have to do an autopsy at a suicidal case. So in a case when there is these cases start, all of them with an external examination, and you find an injury like on the neck, and with the CT you can prove that the hyoid bone is broken, then it could replace in several cases.
And do they country use this method? You mentioned Germany, Austria, for example?
No, they don't, but they use it in England, for example. So there are centers when they use it up to 40% of all the cases. Most of them are natural death cases, and they use something called a calcium score, in which they look at the coronaries, and they decide whether the coronary plaques are severe or not, and then they try to evaluate from that with a high probability whether the person died because of heart failure or myocardial infarct or something like that.
It's a bit similar. My question is a bit similar, but what are the real benefits to use virtopsy to replace autopsy? Like any cost factors or time factors, or maybe because of the cultural background?
Yes, so cultural background is on its own, it's a big thing. So there are countries when they don't do any autopsies because of that. And in countries when it's not the case, then first you start with an external examination. You continue with PMCT, and if you can accept the result, you don't have to go on with the autopsy. So should the number of these cases be high enough, then this could be even a factor in the funds. And also the money you need to spend on one PMCT is much more lower than what you need an autopsy.
So you have mentioned skeletal injury, that it might be effective for that, but the very first results that you showed was saying like we might not use it at all.
In Hungary.
What kind of other outcomes you will be assessing it for? What could you still get out of your data?
All right, we are evaluating injury lesions like cardiovascular lesions, any kind of respiratory lesions. Some of them are promising, so I would say that for like pneumonia it is quite usable, as they use it in COVID, and we have very few cases, unfortunately, for urinary tract infections and for gastroenterology also. But we have several cases in neurology, cardiovascular lesions, and respiratory.
I've seen that you mentioned that you use CT scan with angiography. Yes. It's a possibility. But these are postmortem yes. examinations. How you perform? I mean, without circulation.
Yes, so we have to provide a circulation. We have to have some kind of motor for that, and you have to have an entry and an exit point from the body. This can be done on fresh cadavers only when the vasculature is intact. So you provide an entry point, you push in all the fluid you will use, and on the other hand there is blood coming out, and in most cases in fresh bodies the blood is not clotted yet. So there is that. There is one thing to mention here, that it can cause false positive things to come up, like aortic dissection and things like that, but you have to take that into account.